안녕하세요. 배정인 원장입니다.
Greetings, I'm Dr. Bae Jung-in. Today I want to talk about diagnosis and treatment planning for anterior aesthetic implant cases. Aesthetics involve a significant amount of subjective perception. How can we describe this objectively? A restoration can be considered aesthetically pleasing if it looks natural, harmonizes with adjacent teeth and soft tissues, and satisfies the patient. This can apply to a single tooth restoration or to restoring harmony and symmetry across multiple teeth. Although this description is somewhat abstract, there are indices to describe these aspects. First is about teeth and gingiva. We use white aesthetic score to evaluate teeth and pink aesthetic score to evaluate the gingiva. In 2009, Belzer first introduced the concept of white aesthetic score. The white aesthetic score evaluates 5 elements: tooth form, outline, volume, color, surface texture, translucency, and characterization. Pink aesthetic score was introduced by Fearhauser in 2005 and is recognized as the most suitable tool for evaluating soft tissue aesthetics around single implants. It comprises of 7 elements: mesiodistal papilla, level of soft tissue margin, soft tissue contour, alveolar process, soft tissue color, as well as texture. To summarize, the aesthetics in the anterior region can be evaluated using a white and pink aesthetic score. Knowing what these evaluation items are is more important than the actual scores. Today's topic is diagnosis and treatment planning for anterior aesthetic implants. I want to focus primarily on what not to do rather than what should be done. First, let's look at aesthetic complications. I did a presentation focused solely on this topic last year at the master course, so I'll keep it brief. I'll base the discussion on this paper published in 2022 in Periodontology. This paper addresses 4 different items. If you look at the papers on aesthetics, because a white aesthetic can be covered by lab technique, it primarily addresses aesthetics of pink aesthetics and aesthetic complications. Let's talk about evidence level briefly. Double-blinded randomized controlled trials are considered to have the highest reliability. It is said to have high evidence level. Systematic reviews of these trials are often seen as having the highest level of evidence in conventional literature and are frequently found in consensus reports from major groups like EAO and ITI. The paper I'm discussing mainly reviews meta-analytic studies and consensus reports. It talks about interproximal papilla. It says that there is clear evidence that the papilla is affected by clinical attachment level of adjacent teeth. Before we provide an implant treatment, we need to do periodontal treatment on adjacent teeth first. Contact point and crestal bone. We all know Tarnow. Contact point and crestal point distance should be shorter for better papilla fill. Tarnow has suggested 5 millimeters. However, there is no evidence supporting this exact number. There are contradictory results. This is what we already know. For instance, the phenotype. In other words, a biotype, thick is considered better than thin, but the evidence level is low and there needs to be 1.5 millimeters of distance with adjacent teeth. Regarding implant design, SS and TS types were compared, but they were quite similar. Regarding time of prosthesis installation, opinions are divided over immediate versus delayed loading, though immediate loading seems to show favorable results more. I've thus far talked about single implant. For two implants, the evidence level is not high. There is tendency for a papilla to disappear within 3 millimeters of proximity, hence the recommendation is to do a cantilever instead of placing two implants next to each other. This is an image from the literature. There needs to be 3 millimeters of distance between implants and 1.5 millimeter of distance with a natural tooth. If you place implants like this, papilla will disappear, and that's actually a work of mine. The papilla is mostly gone, and you can see papilla here. Mid-facial mucosal height. Gingival level margin is being discussed. When we evaluate this, the most important and famous is Boozer's comfort zone. It was released in 2004. I think you should take note of this literature. Boozer talks about comfort zone and danger zone. The red is danger zone and green is comfort zone. CEJ level of adjacent teeth. It should be 1 to 1.2 millimeters palatally placed. If it is placed buccally, gingival level can go down. In most cases, you cannot go too palatal. So we've talked about 1.5 millimeter distance with adjacent teeth. This is very important. And next is placement depth. From CEJ of adjacent teeth, you need to place it about 1 to 2 millimeters deeper. Tissue level SS type implant is being discussed in this study. In the case of TS or KS implants, which we use frequently, you need to place it slightly deeper. As for TS or KS type implant, from the gingival margin, it should be placed about 4 millimeters or 3 to 4 millimeters below the CEJ of adjacent teeth. In order to provide aesthetic prosthesis, this is minimum distance to allow designing of transmucosal area, and this is also equivalent to the biologic width necessary to protect the surrounding bone around the implant. In fact, I believe it's better to place implants slightly deeper than 3-4 millimeters, which I'll discuss in the next lecture. Angulation towards the buccal side naturally poses a risk of recession. As for gingival phenotype, like the papilla, it's somewhat contradictory. Commonly, we say a thicker biotype is more advantageous. In the case of immediate implant placement with a thin biotype, there is tendency for significant recession, so it might be better to perform soft tissue grafting when the biotype is thin. Regarding implant design and time of prosthesis loading, limited evidence suggests that platform switching designs like KS or TS type offer advantages. Also, immediate loading tends to preserve gingival margin better than delayed. Soft tissue grafting during implant surgery helps prevent recession, but it does not affect the marginal bone level. Similarly, evidence levels are not high. In terms of aesthetic implant placement, soft tissue grafting is quite important, along with hard tissue grafting. An interesting paper by Wenstrom in 1996 in an orthodontic seminar reported that moving teeth towards the buccal side led to gingival recession, and moving teeth towards the palatal side led to restoration of gingiva. In terms of natural tooth, the ratio between width and height is 1 to 1.5. This is from Nozawa's 2006 paper, which I couldn't find, but it shows as for implant, when the width is 1.5, the gingival height is 1. So the ratio is reversed compared to previous literature. The evidence level may not be high, but it's worth considering. This is from a book that I have, and it summarizes the two previous points. In the case of implant, in order to secure height of gingival margin, you need to have much thicker soft tissue thickness. As a result, soft tissue grafting such as CTG may be necessary. When doing immediate implant placement, gap filling is a must-have, but in terms of gingival recession, it does not show meaningful effect. The reason why we do gap filling is to maintain buccal bone volume. If you look at long-term results, papilla tends to increase. The gingival margin tends to be maintained in a very stable manner. There is no major difference between immediate or delayed loading. Recession can occur 0.2 to 0.5 millimeters, but it's not statistically meaningful. Healthy soft tissues tend to be maintained in a stable manner if the implant has been placed properly. By secondary surgery, this is not about implant placement, but it's about the surgery involved due to peri-implantitis. The prevalence of peri-implantitis is about 20% here, but I think it's actually higher. In order to address peri-implantitis, if you do flap surgery, 2 millimeters of recession occurs almost. When you do implantoplasty, which grinds off the implant surface, even more recession occurs, but by doing a soft tissue graft, you can prevent recession. This is worth memorizing. Let me show you a case. Extraction was decided due to bone resorption. After 1 month, soft tissue healing was observed and implant was placed. If you look over here, there's a little bit of buccal bone loss and GBR was performed. Without inflammation, healing was done, and gingival margin was like this when final prosthesis was delivered. Overall, gingival margin was quite high in the upper left area, so the patient didn't really care. After 6 months, fistula occurred, and you can see a bit of volume insufficiency. Fistula occurred in the connection area. In my opinion, I did the wrong abutment design and chose wrong link abutment. The design was drastic. It was 1 millimeter, but I should have used a 2 or 3 millimeter option. This would not have been a problem, but because soft tissue thickness was thin, various problems occurred. Soft tissue grafting was done. Prosthesis was removed, the soft tissue grafting was done, and for 2 months healing was done. It was quite haste, but 2 months later, provisional was provided, and after 2 months of healing period, final prosthesis was delivered after 6 months. It was delivered 6 months post CTG. We need to look at long-term result, but I think a soft tissue graft would help significantly in preventing gingival recession. I'm going to talk about a different study, not the one from 2022. This was published by Chen in 2014. And this looked at whether the aesthetic results varied depending on whether it was immediate or delayed placement. I'm going to talk about this more in the next slide. And the assumption is that immediate will show more favorable result. We need to pay attention in the point that in immediate cases, recession amount varied. Compared with type 2 and 3, prevalence of recession was more. Also, when there's recession in type 1, facial bone loss was observed in type 2 or 3. In late placement, the frequency of facial bone loss was comparatively less. Depending on how sound the facial bone is, really affects long-term aesthetic outcomes. When the conditions are not very good, when the facial bone is thin or if there is loss, immediate implant placement can lead to unfavorable results. we may need to proceed with early or late placement after certain level of soft tissue and hard tissue healing, and may do implant placement along with soft tissue or bone grafting. Let's look at definitions of immediate, early, and delayed placement. EAO and ITI report slightly different categorizations, especially in terms of surgery. Whereas EAO views up to 8 weeks as early placement, ITI views up to 16 weeks as early placement. ITI divides soft tissue and bone healing. Whereas EAO views up to 6 months as delayed placement, ITI views more than 6 months as delayed placement. The two have similar opinions about loading. Please refer to it. If you take a closer look at 2021 EAO consensus, it talks about impact of timing of dental implant placement and loading. There's also consensus report on soft tissue management. Let's take a look at some interesting questions raised. Impact of immediate provisionalization on aesthetic outcome. Does it help? Previously, people have said it does. Considering evidence level, in this study, they just compared 3 instances of immediate loading, and delayed loading. It says that there's no major difference. In terms of immediate or delayed loading, there were no major differences in terms of aesthetic outcomes. Also, it talks about the soft tissue graft results. Effective soft tissue augmentation on immediate implant placement versus the delayed placement. In terms of mid-buccal mucosa and gingival margin, there was no major differences, but when immediate implant placement and soft tissue augmentation was done, thicker mid-buccal mucosa was observed. Whereas in the case of delayed implant placement case, there was no major difference in terms of thickness. If conditions are favorable, you can get most aesthetic results by doing soft tissue augmentation in immediate implant placement cases. What is the preferable time point to perform soft tissue augmentation? It says that there is still insufficient evidence. You can do it accordingly with different situations. If there's high aesthetic demand, performing soft tissue augmentation is recommended. That is the conclusion. We have thus far talked about how soft tissue augmentation can affect the gingival margin. Let's look at how soft tissue grafting can affect the marginal bone level. Soft tissue and hard tissue augmentation were compared. In terms of marginal bone level, when comparing soft tissue augmentation versus no augmentation, there was no difference. Also, there was no difference in marginal bone level when comparing hard tissue augmentation and soft tissue augmentation. It's not about marginal gingiva. In terms of marginal bone level, soft and hard tissue augmentation showed no difference. I think this still requires more research. Although soft tissue augmentation does not show significant difference in terms of marginal bone level, it is of significant help in preventing gingival recession, so it's very effective. If you look at the ITI consensus in 2014, under the topic of aesthetics, it talks about the clinical condition for immediate implant placement. This is something that we already know. There should be intact socket walls. Also, the facial bone wall should be over 1 millimeters. If it is below 1 millimeter, so when immediate implant placement is done, atrophy can occur. Biotype should be thick. There should be no acute infection. There should be good primary stability. And we need to have corrected 3D position. It should be in comfort zone. If there is 2 millimeters of gap, we need to do gap filling. I'm unsure as to how many cases satisfy all these conditions, but we need to look at the different situations, and if it is deemed that immediate implant placement is more favorable, then we should do it.
이미디어트로 하는 것이 심리적으로 유리하다고 생각이 됩니다.
In the treatment guide, I would like to take note of couple. For accurate positioning, you should use the surgical guide. Provisionals should be utilized for communication with the patient. As for provisional, you should use a screw-retained abutment. We add a crown on top of link abutment. This will be addressed in the next lecture. In many aspects, screw-retained prosthesis should be provided for retrievability or tissue molding. It can be more favorable to modify. In various aspects, a screw-retained prosthesis should be delivered. Also, caution should be taken not to use oversized design for implant and prosthetic components. It can have negative impact on aesthetics. The design of abutment and prosthesis is more critical than the material itself. Through design, you can control emergence profile. You can get retrievability and adjust mechanical properties and strength. This is something that we need to remember. To give you a conclusion based on what has been discussed in terms of treatment planning, review was done on what leads to complications. In terms of material component and selection, it is better to use KS or TS type of platform switching implant. You should not use a thick diameter implant. 3.5 to 4 millimeter diameter should be used. You can do gap filling for the rest of the space. As for the abutment and crown design, this will be addressed in the next lecture. Regarding positioning, when there is multiple missing case, you can use conventional implant placement method to determine where to place implants and where to utilize pontics. However, if the distance between implants is too close, papilla can disappear, so in those cases, you can utilize cantilever as well. In terms of implant placement positions, there is a comfort zone and danger zone. Vertical and horizontally, the distance with adjacent teeth should be 1.5 millimeters, and between the implant there should be 3 millimeters. And from the adjacent CEG level, it should be placed 1 to 2 millimeters palatally. As for TS implant, it should be placed 3 to 4 millimeters from CEJ or marginal level. Preferably, it should be placed deeper, and the angulation should be towards the palatal side. As for bone grafting, to maintain the socket shape, you can do gap filling or do GBR. It does not affect the gingival recession. You need to do soft tissue augmentation to prevent the gingival recession. It is more effective. Soft tissue augmentation can lead to increase in volume, and also it can prevent gingival recession. In areas where aesthetic demands are high, soft tissue grafting is highly recommended. Here it says not to use oversized implant or abutment. Here it says about securing thick soft tissues. As a result, in the buccal side, it is very important to get as much tissue as possible to get aesthetic results. At times, prosthetic design should reflect gingiva as well. Regarding placement and loading, there are opinions that immediate placement and immediate loading is more favorable, and some say there's no major difference. But this is about people who are really good at what they're doing. Preferably, you should do immediate implant placement as well as immediate loading. There are conditions necessary for immediate implant placement. Intact socket wall, over 1 millimeters of facial bone, thick biotype, gap filling. When these conditions are Satisfied, immediate implant placement as well as immediate loading can be done with favorable results. If these conditions cannot be satisfied, you can do early or delayed placement along with bone graft and soft tissue graft. Regarding provisionals, in EAO consensus, it said that there's no major difference between immediate and delayed loading. However, immediate support of soft tissue with the implant prosthesis replacing the extracted tooth may lead to more aesthetic result and can be more satisfying for the patient. I've already mentioned that more so than the material, design is important. Next time I'll discuss the design of temporary and final prosthesis and how to design the transmucosal area as well as the crown. Of course, the patient's health and other conditions along with the clinician's surgical skills are crucial factors.
이런 조건들이 또 마찬가지로 아주 중요한 요소들이라고 얘기를 할 수가 있겠습니다.
Today, we've reviewed considerations for diagnosis and treatment planning for implant placement in anterior aesthetic zone. Today, we have looked at the complications together, and based on that, we also discussed what factors to consider. In online course, we can only address the theoretics, but in offline course, we can address a different theoretical aspect as well as hands-on practice, so we can provide you with a more comprehensive experience. I look forward to your interest. Thank you for your attention.
지금까지 경청해 주셔서 감사합니다.